Good afternoon. First of all, let me give a warm welcome to our guest, Professor Gatringer, microbiologist in an Austrian specialized orthopedic hospital. I'm confident that the expertise of Professor Gatringer will bring forward an important benefit in a better understanding of the topics, which will represent actually the interest of this conference. I will ask him to share his expertise and his experience in a specialized unit from his point of view as microbiologist. Thank you.
So, good afternoon, ladies and gentlemen, dear colleagues. Thank you for the introduction, Dr. Briodescu. Thank you for the invitation to this fabulous congress. Professor Stoike, thank you very much. And as you read, the name of the session is the clinical microbiologist or infectious disease doctors are the enemies or friends to the orthopedic surgeons. I think we can answer this session very quickly and maybe we can stop the session. Yes, we are your friends. But anyway, let me share some thoughts with you, some sentences, why you should work with us and we should work with you. We heard a lot of multidisciplinary approach today in the morning session and afternoon sessions. And I think it's the only solution to solve an infection in an infected patient. Anyway, you're doing a good job. There is no doubt that you bring a lot of life quality to the patient, implanting foreign material, and people love you because they stay mobile. They don't want to lose their mobility. Anyway, and congratulations, your infections rate are very low. So you're doing a lot of operations, but infections rate are very low. But anyway, if there is an infection, it's a devastating situation for you and for the patient. And you need all the help you can get to get out of this disaster. So all the good statistics is worth nothing when there is a patient suffering from an infection. And like always, it's not like this that we live in an ideal world. So it's not like this that you give a little bit of antimicrobial treatment and the infection is solved. So quite often you're facing treatment complicated by complex clinical presentations and limited therapeutic options. As we heard this morning, these patients are very tricky quite often. And what do I mean with complex clinical presentation and limited therapeutic options? They quite often have underlying diseases, diabetes, renal impairment, disparate immune systems. Maybe you have limited surgical options, and as we told before, impaired organ functions. And it's a very challenging side of infection. The bone and foreign material is a very challenging side of infection. As we heard today, you have an impaired pharmacokinetics, a decreased perfusion, antimicrobials and immune system do not get to the infection site. And as we heard before, you quite often have resistant pathogens. It depends where you are, in which site you are, in which country you are. You have to expect some MRSA, some gram-negative problem germs. So you have to act on these patients and to act on these facts. And quite often you have drug intolerance. As we heard this morning, quinolones are quite often a backbone of the treatment, but quinolones are not very well tolerated quite often. Mainly for old people, quinolones are a big challenge, so they get confused or something else. So what should we do now? We have the infected patients. We want the best therapeutic option for the patient. We want to do the best for him. We have it in focus, so we will combine it. We will combine the best antimicrobial treatment from the infectious disease specialist, clinical microbiologist, and the best surgical management. and the best management for the patient will come out. And why there are still barriers of communication and why we wouldn't like to work together. Quite often it's a matter of communication, like always in life, yeah? Communication is challenged by lack of insight into each other's area of expertise. So the orthopedic surgeons don't know exactly what we are doing the whole day in our labs and what we are doing, spending our time. So we should improve the communication between the clinical microbiologist, the infectious disease specialist, and the orthopedic surgeon, and not only the orthopedic surgeon, the clinician. So we can do this with educational programs to get some increased insights of others' areas of expertise, evaluation of work tasks, a review of testing processes. And the authors of this study here, they recommend antibiotic stewardship programs as a valuable framework to get together. So maybe I can give you a little insight what we do the whole day and what our expertise is in this field of infectious diseases. We want to find the microorganism which caused the infection of your infected patient. And so we mixture a lot of different tools. We look at the pathogens, we culture them, we look at the biochemical characteristics. We use a lot of molecular diagnostics and mass spectrometry, and we mix them together. This morning we heard about NGS and the rule of molecular biology. I think just now you can't focus on one diagnostic tool. You have to put them together and then it will work well. And what will you get from us? You will get a valid microbiological result because you want the enemy. As we heard before, it's very, very important that you know which bacteria, which microbiological cause of your infection is there. And there is a big difference if there are staphylococci, if there are Enterobacteriaceae, Pseudomonas aeruginosa, or if you have Candida, you have a little problem anyway. You don't know a lot, or it's not your job to know about intrinsic resistance, but we can tell you this, which antimicrobial substance you can choose. We tell you the resistance and susceptibility patterns. And then you can choose with us the best substance, which is active against biofilm. It's one of the keys in the treatment. The best pharmacokinetic at the site of infection. We heard about today about glycopeptides, about linezolid, about beta-lactams. All of them have different weights. All of them have different penetrations to bone and the site of infections. So we want to switch from the empiric therapy to a targeted therapy. And as we heard before, we want to avoid collateral damage. You don't want a patient which is very sick, suffering from a very severe infection at the prosthetic joint site, and then getting a colitis or a nephrotoxicity or a liver toxicity. And what is very important is infection surveillance and hospital hygiene. All this is integrated in the clinical microbiology, and it helps you to prevent infections, what is the most important than to treat infections. So at all, we have to complete the circle. It's us who have to do the diagnostic stewardship. We want to tell you when is the right test for the right patient at the right time, and we have to complete it and put it in the circle to do the antimicrobial stewardship, to choose the best antimicrobial treatment, to choose the best operating procedure. And it's quite often that clinicians are coming back from congresses like this with a new idea of diagnostic tool, for example, NGS. The last time the anesthesiologists were coming back from a congress and said, we now have to do NGS. Then it's the rule of the clinical microbiologist to tell him, sit down, calm down, I will tell you the truth, and we will put it in our clinical pathways, in our clinical algorithms, and we will look if it's really a useful tool. And it's not an idea of me or Dr. Priotescu that the multidisciplinary staff meeting improves the quality. In this study, they were looking at the impact of weekly multidisciplinary staff meetings on the quality of antibiotic treatment for bone and joint infections. And there are two groups, before they started with this multidisciplinary approach and after implementation of this multidisciplinary staff meetings. And anyway, they saw an improvement in the adaptation of antimicrobial therapy, of optimizing the dose is quite often a theme, that you not have the right dose, that they are low dose, and the rate of treatment failure decreased. And the same in this study. Colleagues compared the outcome of revision surgery for periprosthetic joint infections prior and after implementation of a multidisciplinary team. They saw no significant difference in length of overall hospital stay, but one big benefit was that they knew who to call when they have a problem. So to take some microbiology advice was significantly shorter in the multidisciplinary team. And there was a significant difference in failure rates between the two groups. So they concluded that there is a very optimizing thing to standardized multidisciplinary approach, to implement the standardized multidisciplinary approach, and it shows a significant reduction in failure rates. And these colleagues here from Germany, they were analyzing the treatment success of patients with an infected hip prosthesis who were treated according to a standardized algorithm with a multidisciplinary team too. This was a single-center prospective cohort study, and the conclusion was high infect eradication rates by a multidisciplinary approach. Anyway, treatment or management of infection starts much more earlier. So what we can tell you is optimizing the pre-analysis. We were talking about what about the long way to the lab and so on and so on. We can tell you which sample we want, out of which sample we will get the best results. And this was shown in this study published recently, that if you take the right samples, for example here, deep tissue and bone biopsy cultures from patients suffering from diabetes foot osteomyelitis, then you improve the antibiotic stewardship, you improve the management of the patient. And anyway, why should we change things? There are well-established multidisciplinary teams. We all the time, or today, we heard about endocarditis teams. It's the same with osteomyelitis, it's the same with foreign material infections. So we have to help, and we have to help and to work together to do the best management for the patient. And nobody is asking after the important rule or the sense of a tumor board. It plays an important role in the cancer care. So why we are not doing a multidisciplinary team in infectious treatment? So coming back to the circle, and as you see, we have to complete this circle: diagnostic stewardship, antimicrobial stewardship, and the best operating procedures. How we work in our hospital, when we look at the 3 steps of analysis, in the pre-analysis, we're talking to each other which sampling is the most efficient, how many samples you have to take, how to transport the foreign material in our lab, optimizing the transport of the samples, and so on and so on. The pre-analysis is very, very important to do a good analysis. And that's our point in the lab. We have to do quality-controlled analysis of the samples. We have to be innovative in new tests. We have to implement them. And then we do a weekly meeting to discuss patients with infection problems and creating an individualist care plan for the patients together. So we put our knowledge and the operating people are putting their knowledge, and then it's the best management plan. And another thing we do is the infection surveillance. We take part in big infection surveillance systems. Here we have in our hospital, the German hospital infection surveillance systems, where you can get an interpretation of your own data and you can compare them to other hospitals in Germany and in Austria. And we do, with the orthopedic surgeons, a yearly discussion of the data, and if we see there is a problem earlier, we go to them and we tell them and we look where the problem is. And a very big role the hospital hygiene plays. Regular ward rounds from the hospital hygiene teams on the wards, on the operating theaters, to look how it's going on, how the procedures are, could we improve something. That's regularly done and is a big improvement in the management of the patient. It's a team approach, and I can't just repeat it. It's a team approach involving surgeons, infectious disease specialists, microbiology laboratory, and if you want to get good results too, it's not overemphasized to take a clinical pharmacologist with you. So what we need is a standardized interdisciplinary algorithm for the treatment of bone and joint infections. And we are just discussing about infectious disease specialists, clinical microbiologists, and orthopedic surgeons. At the end, it's a huge amount of healthcare professionals which are necessary to optimize the management of musculoskeletal infections. So at the end of my talk, I just want to leave you with this sentence from Professor Bartlett in 1974. It has long been recognized that frequent contact between the microbiologist and the clinician results in a free exchange of information which facilitates both laboratory and clinical decisions. So from the question from the beginning, if we are friend or enemy, I think there's just one answer. We are your partners, your friends, and we have to work together to get the best management of the patient, to solve difficult infections, to get the patients out of the hospital in a good shape. Thank you very much.
Thank you very much, Professor Gattringer. Now I will continue the presentation.
So it's on me, Dr. Briotescu. She's an infectious disease specialist from Bucharest. Very warm welcome. She is now doing the infectious disease specialist part, and I think after one we have convinced everybody. Thank you.
Thank you very much again. And I start to work with an orthopedic team by 2 years. And I meet a professional team conducted by Professor Stoica. Take a lot of time to accommodate one with the others. But now, my opinion is that we have a good collaboration, and I think that we will start to build a really team. No conflict of interest. Orthopedic surgery implies medical knowledge and technical skills, handling so many tools, using now to do the art. The orthopedic surgeon, in addition to his daily commitment, might become overflowing enthusiast. Also, the patient have to pass through this elective surgery, improving his health, so he is hopeful. In this condition, everybody starts with high expectation. But orthopedic surgery has an enemy. The most significant and threatening enemy is the infection. It's a 0-degree surgery because not one even germ to reach the bones in wound area. Because the bone tissue is a very fertile soil for the germs. This omnipresent cloud that floats over the patient's medical journey can produce at any time the rain, before, during, or after surgery. The clinical signs of a possible infection are subtle, are unspecific, being superposed in both affection, orthopedic or infectious one. This enemy, in this morning we hear a lot about bacteria and how infect the tissues. Are some specific maneuver, of course, by blocking the airflow sometimes of the surgical field due an inadequate position, or maneuver of the anatomical parts of the devices over a large area of the field on the surgical procedure. And of course, in post-surgical time, could achieve the infection in a contiguous way or via bloodstream. Has some particularity, bone infection, because due to etiological agent or presence or not of device, the infection usually, in most of the cases, has a slow evolution. Low inoculum, low energy intake via the blood supply, and germs start to bite, actually, from the tissue to procure this energy, resulting initially a sequestrum followed by the cavity. The best match between the anatomophysiological characteristic of the bones and germs' capability to survive is done by the staphylococcal genus. Osteolacunocanalicular network are invaded by the germs that use various host immune evasion strategies. They behave like spatial security troops, small variant colonies, versatile equipment. In this image, I show the osteolacunar network. This is invaded by the staphylococcal germ that you see decrease the size, and they reach the lacuna where became very, very, has a low metabolic state. They will reside there forever. Actually, the bone infection is named graveyard of germs. It's very difficult for antibiotics to reach and to be effective for the germs in this situation. So, in my opinion, there are some postulates. An osteomyelitis cannot be cured only by antibiotics. And the second is an efficient and adequate treatment implies a surgical debridation and antibiotherapy. This is some picture of a normal bone tissue where the polymorphonuclear infiltrates, and here we see how the inflammation induced by infection bites from the bone tissue. My story, I want to make a scenario for what happens very frequent in our medical practice. My story starts 5 years ago with a patient by 5 years ago, 65 years old woman patient presenting with right knee pain following a long period of standing position or succeeding a long time walking. Her GP ordered an X-ray exam. Based on the symptomatology, physical exam, and the X-ray result, the GP diagnosed the patient with knee osteoarthritis, and he recommended physiotherapy. In these last 5 years, for a period of few months, the patient had no complaint, then started to experience the same type of pain at the same knee, prescription for infiltration with hyaluronic acid or others. The pain has been controlled for a few months. During the whole period to the present, she received 3 more intra-articular infiltration treatments. The pain responded also to non-steroidal anti-inflammatory, and now, being 70 years old of age, she decided to request an orthopedic examination at the Foyshore Hospital. Pathologic history, some high blood pressure under treatment, and an intermittent trigeminal neuralgia related to an old automastoiditis responding to NSAID and other pain relief medication. This is the X-ray image. Lab results show a normal white blood cell, a slight increase of C-reactive protein, and of erythrocyte sedimentation rate. But these high values could be explained also by the patient's chronic trigeminal neuralgia, and the rest of blood tests was in normal limit. At a first glance, seeing the X-ray image, a knee replacement seems to be the immediate decision. But the magnified, I show here the magnified image of the same patient's knee, and in this image, we start to have a new perspective, because the probability that this knee might present chronic spots of osteomyelitis secondary to the multiple knee intra-articular infiltrations cast a shade on the initial spontaneous intention. And here we are see the necrotic area. Okay. So, what would be the best way to find out the diagnosis and the most appropriate treatment? Many options: an exploratory intervention with biopsy followed by the immediate bacteriological and histological exam, an intraoperatory curettage of the suspected area with an ICE anatomopathologic exam targeting the diagnosis of osteomyelitis. And if we have no suspicion of infection, if we are just to the first image, a knee replacement will be proceeded. This is a reality in our country. How many orthopedic units own a top-of-the-line radiologic imagistic capabilities? In order to have an accurate radiologic findings, it's mandatory a specific high resolution. This could be a problem too. In first scenario, applying this standardized approach, an exploratory intervention with biopsy, bacteriological exam, so on. Ideally is to have positive 4 from 4 samples, but in real life happens like this. Immediate lab results, gram smear with rarely polymorphonuclears, no germs. And one of the 4 samples positive, if we have luck, with Staphylococcus epidermidis. So, what are we gonna do? To treat or not to treat as an infection? Yes, I said yes. Of course, we cannot ignore the results. And the patient received, by the protocols, 6 with antibiotics, and then knee replacement was scheduled. Arguments pro this approach is that certify or not the infection. But con imply time and funds consuming and requesting a second step before proceeding the knee replacement. Another risk of infection after the procedure. Second scenario, an intraoperatory cleaning up the necrosis area, sending the tissue sample for an ICE exam. Benefits: the intraoperative frozen section
with histopathological rapid results is an essential method of guiding diagnosis. If the ICE exam results show presence of osteomyelitis, the curettage will continue and repeat the ICE exam until it's negative for polymorphonuclear cell. The outcome and the clinical evolution of the patient might be significantly a different one. Disadvantage, not all the orthopedic units in our country benefit of this special procedure, or most of the histopathological laboratory lack the availability to have a specialist ready to perform the test right away. Even in this condition, should not be taken into account only a negative gram smear exam performed from tissue secretion. It's sometimes the only results that the surgeon have in real time during the operational time. The third scenario, knee replacement, either clinical or paraclinical evolution will be okay, or the patient start to experience pain and the inflammation test became positive. After 3 months, X-ray exam shows infection of the prosthesis. Well, the following care sent us back in the first scenario, but with higher biological costs. Remove the prosthesis, curettage, spacer, bacteriological exam, so on, so on. About the sensitivity test, in my opinion, this test guiding the infectious diseases doctor just to eliminate the ineffective antibiotics. In order to choose the right antibiotic, we have to take in account PK/PD parameters, and better to perform MIC, because an MIC value is more helpful for take the decision. And another opinion is, at the beginning, it's better to cover the worst scenario. A strain could have a different sensitivity profile between phenotypic and genotypic assessment. Genomic printing for gene resistance sometimes is necessary too. I have a lot of cases, and during the time, a patient with multiple intervention and multiple infection sites has, at the first site, a different strain. But when I performed the print, genetic print, the strains were the same. It's better to use at the beginning a de-escalation therapy, hit hard. Then we could focus the treatment after the sensitivity test. About the biofilm, it's very difficult to treat. I think it's sometimes impossible, and it's beneficial to start immediately after the curettage, before the biofilm formation, to start the antibiotic, because it's a better blood supply with more amount of drug that achieve the area. Some data show us that aminoglycoside also has a very good activity on biofilm, acting on biofilm and facilitate the penetration of the other's drug. In this area is a lot of research, is a novel, and are many other, but this already has some very good results. A novel antiplatelet molecule, ticagrelor, which is a specific receptor inhibitor. A minimum 2-step arthroplastia. Sometimes it's better to personalize, not only a very rigid protocol. It's good to analyze all the data in a team with the radiologist, with the microbiologist, with the surgeon. And for final prosthesis, the ICE exam is strongly recommended to establish how much to clean up for a safe implant. From my point of view, for my colleague, orthopedic surgeon, don't forget by the cloud, the best attitude is prevention applying strictly all the procedure and protocols, and early suspicion, agree to postpone a new implant until all appropriate methods are used, ensuring that the future surgery area is considered clean of infection. At the initial evaluation of the patient, the surgeon should ask himself to be or not to be infection here. Thank you very much.
Thank you for the very interesting presentation and the good cases as a good example. This session should be to discuss the role of the clinical microbiologist and the infectious disease specialist. If you surgeons, you need us, or if we need you, no, we need you because you have nice infections. Anyway, the discussion is open if somebody have other opinions, or we haven't convinced somebody. We haven't convinced Professor Stoiker.
Okay, thank you for coming and accepting that session. I must say that it was built in a way with your participation directly in our meetings online. The response to your question is very simple. Look at the hall and you'll see how many persons. Some of them are anesthesiologists, some of them are infectionists. It was a long day, and some of them are orthopedic surgeons. I am one of them. And I created a long day discussion about infections to have in the final moment with your session a discussion, you said, in contradictorium, and to analyze what is really happened in a hospital. Reality is looking like that.
I think the reality is that you, all of them, have already convinced them, so there's no necessity to come.
Yes. I accepted that one collaboration with many years ago. For that reason, we have a microbiologist, we have an infectionist in our hospital. But I must ask my colleague, Vlad, what happened in his hospital, please, because we had a long discussion before that entering in this theater, that you are going home, please.
If you ask me why I don't go home right now, but if you ask me the infection protocol.
Thank you for coming.
Yeah, thank you very much. You are very welcome. But if you talk about our approach about this, yes, my approach, yes, it's very punctual. We are an emergency hospital, so we have different specialities, but unfortunately we don't have a microbiologist dedicated to our department. So the possibility to have a very specific exam for this kind of problem is not possible. Fortunately, for the last 2 years, we have an infectious disease specialist who help us a lot in this field. On the other hand, we have a good collaboration with the National Institute of Disease of Matei Balș, where we do it a lot of sonication, which is in my opinion a huge step forward for the treatment of these infections. So it's not very difficult, it's not very easy if you are not a dedicated hospital like Foișor is, to treat, especially in Romania, this infectious. disease. So right now we are on not so solid ground in this field, and now we are very focused to avoid this infection. And it's my strong belief that this approach is more important than other aspect. So we are focused to have a clear environment in our OR, to have strict rules and strict set of rules to avoid these infections. In the other hand, the antibiotics used like prophylaxis is another aspect, and this aspect wasn't discussed today. The second generation cephalosporin, I think it's enough, in my opinion, a single dose. And I want to ask my colleague if they agree with me, then single dose is the most efficient approach.
Surgery, actually, yeah, usually
I
we
talk
are
about
using
joint replacement, and that's all.
primary,
Yeah, primary.
not revision, not tumoral prosthesis and so on.
No, for primary, a single shot.
Yeah, it's
okay?
enough. But sometimes, you know, after these single doses postoperatively, you will face, let's say in 3 days, something that looks a bit pathological in the wound. What you doing then?
Forget about antibiotics.
But I think we are leaving the discussion, because the discussion was first why orthopedic surgeons are not interested in microbiology. This was the first question I understood from Professor Stoiker. And the second one is to describe the situation in your hospital. And when I listen to you, you have a very good situation because you have a microbiology lab you're working with. It's not in your house.
No,
and
it is. It is.
It is.
It is. But for special cases, we don't have sonications. So,
but sonication is really easily implemented, and you have an infectious disease specialist. So you have all the tools to treat an infected patient properly.
Except the money to buy the machine for
The sonication is not that expensive.
It's a very cheap one.
If I buy by myself,
It's a box. It's very less. It's not like your car.
But
It's a
if
very
you...
small
So you
device.
propose to me to sell my car?
But where did you say, sorry, where did you say you sent the prosthetic material to sonication? To another institute. So it's perfect too. So you just have to look at it, that the way for the sample is optimized, and that you have a good communication with this institute. So you will get all the informations you need and which your IT specialist is needing, that you can treat the patient properly. And
That's right. That's right. And I already told you we have this kind of approach for more than 5 or 6 years.
It's very organized. Thank you very much. And that special box, it's a box with ultrasound, nothing else. Thank you. How is functioning Iași Recuperation Hospital? Please.
Nothing about
It's a big center, university center.
nothing about it.
Professor, I am very serious. I'm asking you, please. No.
it's working perfectly.
They haven't a
They are not
microbiologist and infectionist. Okay, let's go to another hospital, very important, an emergency one. Please say something about microbiologist and infectionist.
I cannot complain. According to that discussion, I have microbiology lab and infectionist specialist. So I have enough. It's functional, of course, but
It's a good collaboration.
a good collaboration, but difficult.
It's
difficult.
a very good why this.
Why it is difficult?
Because our infectionist must to work with all the specialties. Is not specialized on our field.
That means the treatment, antibiotics are
Not
given
always,
by an infectionist, not by orthopedic surgeon.
Yes, by an infectionist in our
It's
field.
very nice.
Yes.
Thank you.
Yes.
And another one, it's pediatric hospital, the new one from Romania, made in the last 20 years, Gomoyo Hospital. It's a very nice hospital. And my colleague is chief of the service. Please.
Hello, thank you for the opportunity to be here. Fortunately, in children, we don't have so many problems with the infections as you in adults, because we are on a very, very friendly environment with the kids. So we have few infections on material. As Dr. Stoica says, we are at the very beginning. We don't have real infectious disease laboratory, but we collaborate very well with the two infectious disease hospitals in Bucharest, and when we have problems, we send them the material for sanitation and so on.
Okay, another hospital, emergency one, is named Elias Hospital. I'm discussing with my colleague, chief of service. Please.
Hello, I am Dr. Gheorghiu from Elias University Hospital. We have a department for total arthroplasty for hip and neck, but what to see? I don't have a doctor, microbiologist, specialist in these cases. And our department don't have many cases, infection, because I don't know what's happened with this patient. Sorry, it's not my department. I'm not head of department. The situation is complicated.
Okay, thank you very much. And now a colleague from Cluj-Napoca. It's other part of the country. Please. What happened in your department? The question was, you was not here. If you have a microbiologist and an infectionist, and where is the place for both of them in your hospital, in your clinic?
Hello, everybody. So we have a microbiologist in our hospital and an infectionist in emergency county hospital of Cluj-Napoca, and we collaborate with them all the time. We need an advice. We ask them for an opinion, not maybe for the first line treatment, but for complicated cases with multi-resistant drug bacteria, or in cases in which we cannot control surgically, and with the treatment, the first line treatment, the septic process. And of course, for septic complications of the patients in the hospital, so for nosocomial.
So it's working quite well over there.
Yes, we have that collaboration.
It's a good collaboration.
Is somebody very modest here, an orthopedic surgeon in Agija. It's a small hospital, but put it in a very important area, of trauma area. Please say something.
I'm in an external department of a big hospital. We treat only the infection, diabetic foot, or infection of the spine. And we collaborate with the microbiologist in the big hospital. And we have an infectionist, but the collaboration is not so good.
Why? You don't like him?
No, we confront with Clostridium difficile in very lot of cases. And the infectionist in more cases asked to be more effective with this complication.
But that would be a good approach for a discussion in a multidisciplinary panel, because normally when you have a problem with Clostridium difficile, you have a hospital hygiene problem. So it would be a good approach to sit together, all of them, infectious disease specialist, hospital hygiene, microbiologist, and find the best solution. So you have everything over there, so start to discuss.
Yes, of course.
I am in the area of Foishor Hospital here. All of them, they are coming to help us, not to be interested because they have microbiologist and infectionist. And I ask them if they intend to say something about. They don't say something because like my colleague from who invited you, and in that way we find a way to come here, with my colleague and friend Ramadani, Florin, and said me that you made order there. It's very important. How it's possible, like a microbiologist and an infectionist, to be predominant for the orthopedic surgeons? The others, if you look for the faces, are not very happy.
They are, they just can't show it.
I'm trying to speak Florin something about you, and after that to say how it's possible to be okay fighting with science adequately. Is it a way, a special way to resolve the problem of hospital, or combine interest of all of them?
It is in our interest to be together. No. Definitively, I am famous not to be politician, so I am controversial, discreet person. But we are really, definitively in the very good situation from the time from Dr. Gattinger to have in hospital, because at this time we have perfect collaboration, because we need the microbiologists and clinical infectious. We need this because we are in some cases in the problem, what kind of antibiotica, what is the combination, how long to give this and this and this. That's why it's a really, in our hospital we are not department from traumatology and orthopedics. We have all the departments, general surgery, urologists, and also big department of the cardiology with more problems with different germs. That's why it's really, for my opinion, one hospital without a good microbiologist, it's a definitely big minus for hospital. That's why I recommend and I prefer to have one person like Dr. Gattinger or like Dr. Protescu, and the collaboration, it's really the goal to come in the good results, combined surgery, debridement, and the finish with antibiotic therapy.
Thank you, Florin. For that reason, I put it my colleague and invited you, because after 2 days sessions of different interest areas, my colleagues asked me, why did you put 500 places for infections and for spine? Because we don't need it. We are operating, and another colleague, because I'm chief of the register, asked me, do you have some money for a new service to start to implant some prosthesis? And I said, you are here or in the infection area? To learn before what's happened and how to treat. Because in general, when they have an infection in a hospital, send it under the covering name TB to Foishor, because Foishor is resolving TB. But in the back, it's ECBL resistance, a lot of germs. I think it's the duty who is implanting to resolve the cases first. Second, it's not necessary to do something like technique. You must listen and to put a diagnosis and to send to another colleague who is doing. For that reason, I created places to have not in the other theaters, to come here to listen and to put and to examine a spine to know how to discuss, to make an approach for infection and so long. But was not really a success in this moment. I hope in the future we need more discussions, more pressure for the chief of services, for everyone, and to create this mechanism and to function. Because we need a lot of microbiologists in Romania in this moment, we haven't. And another one, it's infectionists to be involved in a hospital. Without is not functioning. I saw an invited speaker in the section of Dr. Bărluțiu, an orthopedic surgeon who has a proper manner to treat the infections like orthopedic surgeon. I agree that. I am not that feeling, but I think we need more science, more experience, and your specialties.
Yeah, but what thank you for the sentences now at the end. What I think and what I saw, you have infectious disease specialists. Maybe you have microbiology lab, so there is the opportunity to come together and to take a multidisciplinary approach. So I would recommend you just to talk to each other, and it should be on an eye level, and both of us will profit from the collaboration. So we will end the session.
Yes, I want to thank you very much. I want to say to you that it's difficult to build a team, but we have to have patience and to be more trustful in our action. Thank you.
Thank you very much for coming and for this session. I think we need more discussions, and we are waiting again for the next Congress. Thank you very much.
Yeah.